Before we get into the main film, I want to give you 5 minutes of context that will make everything that follows make sense. There are 4 moments in this material where general dentists typically pull back because the content stops looking like dentistry. I want to walk you through those 4 moments before we hit any of them. By the time we start the main film, you'll have the lens already in place. The first reframe, we're going to talk about posture, the pelvis, the diaphragm, the psoas muscle. And the moment we do, the natural reaction is, I'm a dentist. Why are we talking about the pelvis? Here's why. Try this right now. Sit up straight, tilt your pelvis forward, push your low back into a deeper arch. Notice what happens to your head. It comes forward. Notice what happens to your jaw. It drops back relative to your skull. You just demonstrated the entire postural framework in 5 seconds. The patient's jaw position is the last domino in a chain that starts at their pelvis. The patient with a forward tilted pelvis develops forward head posture. Forward head posture pulls the mandible back relative to the skull. The masseter has to clench all night to maintain occlusion against that displacement. That's why your bite splint sometimes plateaus. The splint is fighting a force you couldn't see. Once you can see the chain, you can refer the patient to a postural therapist who corrects what's upstream, and your dental treatment finally holds. The second reframe, we're going to talk about sleep apnea, CO2 physiology, the Bohr effect, oral appliances and myofunctional therapy, and the reaction is, that's sleep medicine. Why is this in a dental film? Here's why. The pharyngeal airway sits directly behind the structures you work on every day. The mandible, the tongue, the soft palate, the hyoid bone. These are the architecture of the upper airway. Every dental exam is an airway exam. You're already looking at it, you're just not always reading it. And here's the urgent part. Every time a patient stops breathing at night, the body experiences a cortisol spike. A sympathetic surge, a destruction of deep sleep, and a hypoxic insult to every tissue. That's why obstructive sleep apnea is associated with hypertension, diabetes, Alzheimer's, depression, and refractory dental cases. You are the practitioner who sees the upstream anatomy. If you don't screen, nobody does. The film is going to teach you how to screen, when to refer, and what dental treatment fits into the picture. The third reframe, we're going to talk about 3 pieces of biometric technology: a joint vibration analyzer, a digital occlusal force map, and surface electromyography for the masticatory muscles. The reaction here is, this looks expensive, this looks specialized, this looks like commitment to a whole different kind of practice. Here's the truth. Every one of these devices is reading exactly what your hands, eyes, and ears already read. They just read it with more precision. Your fingers on a TMJ during opening are detecting vibration. The analyzer quantifies the same vibration and breaks it down by frequency. Your articulating paper is reading force distribution. The digital map adds the time dimension. Your palpation of a tense masseter is reading muscle activity. The EMG quantifies it in microvolts. You don't need to own any of this equipment to start. You don't need to master it on day one. What you need is to understand what each instrument measures and what the numbers mean. The film will give you that. The equipment comes later. The fourth reframe. By the end of the film, we're going to be talking about root cause hierarchies and inter-system interactions, monitoring dashboards, and the refractory case algorithm. And the reaction is, this is starting to sound like functional medicine. I'm a dentist. Here's the distinction. The film is not asking you to practice functional medicine. It's asking you to think like a systems clinician within your own dental scope. Every clinical field has its systems clinicians, the few practitioners who can hold the whole patient in their head, identify what's upstream, and coordinate care. Dentistry has been missing those clinicians. The framework you're about to see is what produces them. The single most important idea in the entire film is this. The patient who improves and then stops improving is not a treatment failure. The plateau is the most precise diagnostic signal in clinical practice. It tells you exactly which upstream variable hasn't been addressed yet. Once you can read a plateau, every difficult case in your practice becomes a puzzle worth solving instead of a frustration. 4 reframes: the pelvis, the airway, the biometric technology, the systems clinician way of thinking. Each one looks foreign on the surface. Here's the one thread that runs through all of them. Every cell in the body runs on a tiny electrical battery, the mitochondrial membrane potential. When that battery is charged, tissue heals, muscles relax, sleep restores, and your dental treatments work. When the battery drops, none of that happens. 8 specific things keep that battery charged. 3 of them sit inside dentistry: the structural pattern, the airway, and the bite. When you understand all 3, your practice changes. That's the film you're about to watch. Let's begin.
Before I tell you what POMC is, I want you to do one thing. Think about 2 patients you have probably seen this week. Both clench or grind, but they present completely differently. Patient 1, mid-40s, overweight, high-stress job. They don't really grind, they clench. Steady, sustained clenching. Their resting masseter on your bioEMG is elevated even when they're not talking. They wake up wired in the middle of the night. Their morning cortisol is high. Patient 2, often underweight or weight cycling. Doesn't eat enough protein. They have been chronically stressed for years and are now burned out. They grind audibly. Their partner can hear it. They wake up at 3 a.m. and can't fall back asleep. Their morning energy is flat. Both temporalis muscles are tender. These are 2 different patients. They have 2 different underlying biological mechanisms, and they need 2 different interventions. The biology that explains it is POMC. POMC stands for propiomyelanocortin. It's a protein made by a specific group of neurons in the hypothalamus, the brain's control center for energy and stress. When POMC gets cleaved, it does 3 things. It tells you when you've eaten enough, generates a feeling of well-being, and regulates your autonomic nervous system. In plain terms, POMC is the brain's master switch for whether you feel good, satiated, and energetically balanced. When it's suppressed, the body fails. 2 things suppress POMC. One is chronic cortisol, which chemically silences the gene. The other is omega-6 membrane loading from a poor diet. Pattern A is the membrane problem. The patient's cell membranes are loaded with omega-6 fatty acids from seed oils and processed food. The melanocortin receptor sits in those membranes. When the membrane is stiff and pro-inflammatory, the receptor doesn't respond properly. The signal isn't getting through. Clinically, pattern A is the sustained clincher, the steady, all-night activation. The patient is sympathetic dominant and wakes up feeling wired. On exam, these patients have the right dominant structural pattern and forward head posture. Their diet is high in seed oils and ultra-processed food. Pattern A responds to omega-3 repletion and dietary changes. The bite splint helps, but it's only treating the symptom, not the membrane biology. Pattern B is the methylation problem. This patient has had elevated cortisol for years from chronic stress, poor sleep, or airway issues. That sustained cortisol activates an enzyme called DNMT3A, which chemically silences the POMC gene. Production is reduced at the source. Clinically, pattern B is the burned out grinder. They wake up early, at 3 a.m., and can't sleep. Their morning energy is flat, and their HPA axis is burned out. Their diet often involves restriction and low protein. This nutritional inadequacy contributes to the POMC suppression rather than fighting it. Pattern B responds to addressing the drivers in sequence, the structural, airway, circadian, and gut levees. This allows the gene to demethylate over time. The dentist who can distinguish these patterns has a real clinical advantage. Here is how to do it in 2 minutes. First, ask about the parafunction. Pattern A is the sustained clincher. Pattern B is the rhythmic, audible grinder. Second, ask about sleep. Pattern A has trouble falling asleep. Pattern B wakes early and can't return. Third, morning energy. Pattern A wakes up wired. Pattern B wakes up flat and drags through the morning. Fourth, the body and diet. Pattern A shows central adiposity and high seed oils. Pattern B shows restriction and low protein. Fifth, if you can, use a morning salivary cortisol strip. Elevated for pattern A, low to normal for the exhausted pattern B. The bruxism patient who isn't responding to your splint, or the TMJ patient who relapses. Many of these are POMC suppressed patients. Dental treatment alone cannot resolve them. Once you identify the pattern, 3 things change. You set realistic expectations. You refer correctly, and you monitor differently. Monitoring is key. The HRV deep sleep peak is diagnostic in pattern B because POMC restoration requires deep, slow wave sleep. Systemic intervention is the functional medicine practitioner's role. Your job is recognition, sequencing, and the dental side support for overall recovery. The brain's master switch shows up in your operatory every week. Now you know how to read it. Now, let's look at the next part of the framework.
The Living Energy series was built on a single organizing assertion. Life is organized electron flow, and disease is its disruption. This is not a metaphor. It is a statement of biochemistry derivable from first principles of thermodynamics and electrochemistry. Electrons move through biological systems the way water moves downhill, thermodynamically driven toward lower energy states. In the mitochondrion, the electron transport chain is the hill. Energy is stored as a proton gradient across the inner mitochondrial membrane. The result is a concentration and charge difference, the battery that powers ATP synthesis. ATP synthase is a molecular turbine. Protons flowing through it drive its rotation, converting ADP and inorganic phosphate to ATP with each turn. The ATP synthesis threshold is a cliff, not a slope. Below the minimum threshold, production doesn't just reduce, it stalls entirely. The patient has cellular energy failure. The series identifies 8 upstream levees, 8 input categories that each reach the membrane potential through a distinct molecular mechanism. Every clinical chapter derives from them. Ultimately, a clinician who understands this physics can predict biological responses. Disease is physics interrupted, not chemistry gone wrong. Dentistry applies force to biological tissues continuously and deliberately, but what is the hidden physics behind these forces? The piezoelectric effect is the generation of an electrical potential in a material subjected to mechanical deformation. In collagen, this mechanism derives from the triple helix's non-centrosymmetric geometry. Compression produces a negative potential, tension produces a positive one. Bone is a composite material of collagen and hydroxyapatite. Both contribute to bone's piezoelectric behavior through molecular signaling and streaming potentials. Wolff's law, bone adapting its structure to mechanical demands, is at the molecular level a piezoelectric phenomenon. Signals direct bone formation and resorption. In orthodontics, the compressed ligament fibers generate potentials that promote bone resorption, while tensioned fibers promote new bone formation. The Piper classification's progression in the TMJ is, at its core, a sequence of failed piezoelectric adaptation to chronic maldistribution of force. By normalizing the mechanical loading, we normalize the piezoelectric signal field, redirecting the remodeling trajectory back toward joint health. Vibration is the oscillatory motion of a physical system. In the TMJ, every vibration carries encoded data about the health of the joint. Every vibrating system has 3 fundamental parameters: frequency, amplitude, and damping, the rate at which the system loses energy to its environment. 3 mechanisms produce TMJ vibration: a high-energy impact like a disc recapture click, a sustained friction event like crepitus, and synovial fluid turbulence. The TMJ's behavior is governed by viscoelasticity. Materials like the articular disc both store energy elastically and dissipate it as heat through viscosity. Viscous energy dissipation is the disc's primary function. It prevents high-frequency transient loads from damaging the condylar and fossa fibrocartilage. The Fourier transform is the mathematical tool that converts a time domain signal into a frequency domain representation, quantifying clinical observation into bioenergetic measurement. Because tissue damping acts more strongly on high-frequency components, the peak frequency distribution, rather than total integral, drives our diagnostic interpretation. By mastering these physics, we move from qualitative listening to precise quantified measurement of biological tissue health. Why does the pharynx collapse during sleep? The answer is not purely anatomical, it is fluid mechanical. Bernoulli's principle states that as flow velocity increases through a narrowing, the static pressure on the walls decreases, facilitating collapse in a flexible tube. The Starling resistor model describes the upper airway as a collapsible segment. This segment has a critical closing pressure, P-crit. P-crit is determined by the bony frame, soft tissue volume, and dilator muscle activity. Any pressure above 0 leads to frank obstructive sleep apnea. The Reynolds number predicts airflow transition to turbulence. In the nose, this turbulence humidifies and warms air, protecting the lower airways. By the Hagen-Poiseuille law, even modest reductions in pharyngeal dimensions produce disproportionately large increases in airway resistance. Oral appliance therapy works by advancing the mandible, increasing cross-sectional area, and effectively reducing resistance by nearly 50%. Orofacial myofunctional therapy acts as a real mechanistic synergist, improving muscle tone to reach therapeutic goals with less mechanical advancement. The most clinically consequential misunderstanding in respiratory education is that oxygen is the primary driver of breathing. It is not. The central chemoreceptors respond to arterial pA-CO2 changes with a latency of seconds. The system is designed to regulate CO2 with precision. Carbonic anhydrase is a zinc metalloenzyme. Zinc deficiency impairs the CO2 transport mechanism that maintains pA-CO2 stability. The Bohr effect is the biophysical mechanism where reduced CO2 causes hemoglobin to hold oxygen more tightly, impairing tissue delivery. For the chronic hyperventilator, this means a nearly 30% reduction in tissue oxygen delivery. The resulting brain fog and fatigue are mitochondrial consequences. In the habitual hyperventilator, the narrow CO2 margin produces central apneas that are often masked by obstructive events. The Bolt score is our clinical proxy for the pA-CO2 set point. A score below 15 seconds identifies the patient with a low CO2 tolerance and dysfunctional breathing. Life is organized electron flow. By mastering these physics, we empower the bioenergetic practice to restore the living world. The BioEMG isn't just a recording, it's a measurement of the physics of the motor unit. Today, we look at what that signal actually means. Placing electrodes on the masseter detects a voltage gradient created by extracellular current loops. This signal decays with distance, but is detectable with sufficient amplification. A single motor unit, from 3 fibers to several hundred in the masseter, generates a compound extracellular voltage known as the motor unit action potential. The 2 microvolt threshold is 2 to 4 times the noise floor. A hyperactivity ratio of 15% means the muscle is generating 15% of its max force at rest. This continuous contraction has a metabolic cost in ATP and calcium handling, the substrate of morning jaw soreness and temporal headaches.
Before I give you any anatomy, I want you to do 2 quick things with your own body. Then the rest of this will make sense fast. First thing, sit up straight. Put your right hand on the right side of your lower ribs, just below where your bra strap or shirt seam would be. Put your left hand on the same spot on the left side. Now take a slow breath in. Pay attention to which hand moves more. For most people, the left hand moves more. The right side feels stuck. That asymmetry you're feeling right now is the foundation of everything we're about to discuss. And here's the part that matters. That same asymmetry is the reason your patient's jaw clenches at night. Stay with me. Second thing, without moving your shoulders, slowly tilt your pelvis forward. Push your belt buckle down toward the floor and exaggerate the arch in your lower back. Notice what happens to your head. It moves forward. Notice what happens to your jaw. It drops back relative to your skull. You can feel your bite shift. You just demonstrated the entire structural framework on your own body. Now let me explain why. The human body looks symmetrical from the outside. The inside isn't. The liver, which weighs about 3.5 pounds, more than any other internal organ, sits on the right side of the body, directly underneath the right diaphragm. The heart sits on the left side, pushing the left lung out of the way. The stomach is on the left. The colon is asymmetric. Even the diaphragm itself is asymmetric. The right half attaches to the spine through 3 vertebral attachments, the left half through only 2. None of this is pathology. This is normal human architecture. Every patient sitting in your operatory has the same internal asymmetry. Here's the physics. The liver pushes the right diaphragm up into a more domed shape. The law of Laplace says that a more domed structure generates more pressure per unit of contraction. So the right diaphragm is mechanically stronger than the left, every single breath. Now think about how many breaths your patient takes. About 20,000 a day, 7 million a year, 300 million in the course of an adult lifetime. The right diaphragm pulling slightly harder than the left, 300 million times. That asymmetric pulling is what slowly torques the body, and the torque ends in the jaw. Let me trace the chain from the right diaphragm to the mandible. Step 1. The right diaphragm pulls harder. The right side of the rib cage gets dragged downward and inward more than the left. Over time, the right ribs rotate slightly forward, and the right thorax shifts to the left of the body's midline. Step 2. The pelvis compensates. To keep the body upright, the pelvis shifts forward on the right and backward on the left. The left hip rolls into internal rotation. The body's center of mass moves to the right. Step 3. The left psoas has to work continuously to keep the body from collapsing into that rotated position. That left psoas runs directly next to the lumbar sympathetic chain, the nerve trunk that activates the fight or flight response. Sustained psoas pressure on the sympathetic chain elevates cortisol and suppresses heart rate variability all day and all night. Step 4. The elevated sympathetic tone drives chest breathing instead of diaphragmatic breathing. The ribs lift higher than they should. The diaphragm flattens. The neck muscles take over the work of breathing. Those neck muscles, the scalenes, sternocleidomastoid, upper trapezius, pull the head forward. Step 5. The forward head moves the skull anteriorly. The mandible hangs from the skull through muscles in the temporomandibular joint. When the skull moves forward, the mandible gets dragged posteriorly relative to where the skull is now. The condyles compress into the retrodiscal tissue. The masseter has to work harder to maintain occlusion in this displaced position. The patient clenches all night. That's the chain. Right diaphragm to pelvis to sympathetic chain to displaced mandible. The bruxism you're treating starts in the patient's chest cavity. One more thing, the diaphragm is not just a breathing muscle. It does 3 jobs simultaneously, and all 3 matter for your dental patient. Job 1, breathing. The diaphragm contracts downward, the lungs expand, air comes in. Standard physiology. Job 2, spinal stabilization. When the diaphragm contracts, it creates intra-abdominal pressure that stiffens the trunk. This is how the spine stays stable. The patient with an asymmetric diaphragm has chronic low-grade core instability, which compounds every postural problem in the body. Job 3. Heart rate variability. Every inhale and exhale squeezes the heart's venous return slightly, generating beat-to-beat variation. When the diaphragm flattens and loses its zone of apposition, all three jobs fail simultaneously. Breathing gets shallower, the core gets less stable, and HRV drops. This is why your patient's wearable HRV reading is partly a mechanical readout of their diaphragm, not just an autonomic readout. Every adult patient has been pulling slightly harder with their right diaphragm for decades. The cumulative torque has reached their jaw. You are seeing the final domino. What you need is to recognize the pattern: the right shoulder elevation, the forward head, the right side dominant masseter hypertrophy, and refer to a postural therapist who can address what's upstream of the jaw. Once that referral is in place, your bite splint doesn't plateau. That's why visceral architecture matters in dentistry. The patient's jaw is the last domino. Now let me explain the rest of the framework.
The body is not symmetrical. Its visceral architecture is inherently asymmetrical, and our musculoskeletal patterns are a rational adaptation to that reality. The liver on the right makes the right hemidiaphragm more domed than the left. By the law of Laplace, this generates 33% greater pressure per unit of force. Compounded over 20,000 breaths a day, this asymmetry drives the left AIC pattern, a rightward torque on the thorax that the pelvis must counteract. The left psoas major's chronic shortening is maintained by anterior pelvic tilt. Its proximity to the sympathetic chain is where structure becomes sustained upregulation. The goal of restoration isn't symmetry, it is variability. We want to give the organism access to both sides of the neuromuscular spectrum. Structure is an autonomic variable. The patterned body is under continuous mechanical load, driving chronic sympathetic activation regardless of stress levels. Mechanical pressure on the lumbar sympathetic chain lowers the firing threshold of neurons via piezo channels, increasing spontaneous firing probability and cortisol load. In forward head posture, the compressed suboccipital complex alters the mechanical environment of the jugular foramen, suppressing the vagus and attenuating HRV. Chronic masseter activity generates a trigeminal barrage that upregulates the brainstem's arousal network, preventing the nocturnal cortisol nadir needed for deep sleep. HRV is a structural marker. If the ear is anterior to the acromion and the jaw is clenching, no biochemical intervention will fully restore autonomic health. The diaphragm performs three roles simultaneously: respiratory driver, postural stabilizer, and autonomic regulator. Today we explore how they are coupled. The zone of apposition is where the diaphragm fibers run vertically. When the ZOA is lost to rib flare, the diaphragm works against itself, increasing respiratory work. The trunk is a hydraulic cylinder. Anterior pelvic tilt disrupts the inferior piston, forcing the paraspinals to compensate for the lost internal pressure. HRV is mechanically generated. A diaphragm with full ZOA creates a large pressure swing that amplifies the vagal tone measured in respiratory sinus arrhythmia. The ZOA is the anatomical hinge. We must establish posterior pelvic tilt first to restore the ZOA and sustainably correct the cervical spine. The structural levy is unusual. Its failure produces simultaneous effects across all other levies, acting as an unaddressed upstream driver of biochemical plateaus. Co-contraction creates a continuous mineral drain. Persistently low RBC magnesium levels are often the result of filling a bucket with a structural hole in it. Structural cortisol elevation downregulates claudin-1, increasing gut permeability and triggering the neuroinflammatory cascade we've identified as pattern B. The postural chain ends at the airway. Forward head posture reduces the retroglossal area, elevating pCrit toward the range of obstructive sleep apnea. The structural assessment isn't an afterthought. It is the first clinical act that determines if biochemical interventions will ever truly take hold. The 90-90 hip lift with balloon is the most mechanically sophisticated single exercise in the PRI protocol. It is a masterpiece of restoration. It addresses four structural problems at once, inhibiting the left iliopsoas and right paraspinals while restoring the diaphragm's zone of apposition and facilitating hip stabilizers. Success begins with precision. 90 degrees of flexion maximizes joint congruence and positions the iliopsoas at its resting length, avoiding the dominance of a shortened state. The balloon is not a prop, it is a mechanism. Expiratory pressure recruits the internal intercostals and obliques through a respiratory pathway that bypasses suppressed volitional control. Each breath is a ZOA restoration. The balloon's resistance drives the diaphragm to its highest dome position, correcting the chronically inhaled state that plagues the patterned body. We must guard against substitutions. The Valsalva bear-down or lumbar extension can mimic the movement while bypassing the intended neuromuscular correction. Inhibition opens a window. Facilitation of the left gluteus medius must follow within 60 seconds, while the neurological suppression of the pattern is temporarily reduced. The restoration follows a 4-week progression, from initial inhibition and facilitation to standing integration and finally, loaded movement in the corrected pattern. Restoring the frame is the first step toward the airway levy. In video 2, we'll verify this success through the 3-marker confirmation. The structural protocol produces its effects through physical mechanisms that appear in physiological markers. We confirm success through 3 specific signals. Marker 1, the BOLT score. It is our clinical proxy for the CO2 set point and ZOA status. As tidal volume increases, the BOLT score gradually normalizes. Marker 2, the nocturnal RMSSD deep sleep peak. Its presence confirms stage N3 access and the normalization of the trigeminal RAS arousal threshold. Marker 3, Bioenergetic resting masseter normalization. This tracks the masticatory motor pool's tonic drive as the ascending postural chain corrects mandibular displacement. The trajectory is predictable. BOLT improves by week 2, masseters begin to fall by week 4, and the deep sleep peak emerges by week 8 of consistent compliance. Divergent trends are diagnostic signals. An absent deep sleep peak despite BOLT improvement identifies a persistent trigeminal RAS mechanism requiring further assessment. Verification is the key to clinical mastery. In video 3, we'll explore the physics of the airway, the gating mechanism of all bioenergetic restoration. The airway is not merely one levy among 8, it is the gating mechanism that determines whether any other levy's restoration can occur. Pharyngeal patency is governed by the cold physics of pressure. We quantify this risk through PCRIT, the single number capturing an individual's obstructive risk. PCRIT is determined by 3 factors: the skeletal dimensions of the bony frame, the volume of soft tissue within it, and the neuromuscular tone of the pharyngeal dilator muscles. Each obstructive event produces a stereotyped cascade that damages every bioenergetic levy, triggering the Mueller maneuver and the hypoxia reoxygenation cycle. Inspiratory effort against a closed airway generates massive negative pressure swings, stretching the cardiac chambers and depleting the antioxidant systems. This intermittent hypoxia activates the Warburg metabolic shift, where the catabolic signals of OSA compete with and attenuate the anabolic benefits of Zone 2 training. AHI often understates the bioenergetic burden. Upper airway resistance syndrome produces the same sleep fragmentation and sympathetic activation without meeting the AHI threshold. We must look beyond AHI to the T90 exposure, the slow wave sleep percentage, and the nocturnal RMSSD average to assess the true bioenergetic burden. Mastering the physics of the airway is the key to unlocking the recovery of all 8 levies. In video 4, we'll explore craniofacial development. The craniofacial skeleton is not a fixed blueprint. It is a functional architecture that grows in the direction of the pressures applied to it, following the principles of Wolff's law. Genetics provide the potential, functional inputs determine its expression. Nasal breathing and tongue-to-palate posture are the primary stimuli for proper maxillary development. The maxilla and nasal cavity are developmentally inseparable. The tongue's resting pressure provides the sustained outward force required to drive the lateral expansion of the mid-palatal suture. The narrow maxilla is both the product and the perpetuator of mouth breathing. Reduced nasal area increases resistance, trapping the patient in a cycle of structural and habitual dysfunction. Success depends on the plasticity window. The suture is maximally responsive between ages 4 and 12, transitioning to required miniscrew-assisted or surgically assisted expansion in adulthood. Mandibular length follows its own window. Functional appliances are most effective at the CS3 maturation stage, marking the peak of pubertal skeletal growth and the optimal timing for intervention. Pediatric OSA is a developmental bioenergetic emergency. Untreated obstruction disrupts the sleep architecture during which the brain's baseline and mitochondrial resilience are constructed. Understanding the windows of growth allows us to intervene when the levy is most plastic. In video 5, we'll dive into the depth of CO2 physiology. Chronic hypercapnia is not just a respiratory issue, it is a multi-system disease. Carbon dioxide is a powerful biological regulator, and its depletion has profound consequences. CO2 is a master vasodilator. A resting pCO2 of 32 mm reduces cerebral blood flow by 16%, producing the characteristic brain fog and word-finding impairments of the hyperventilator. Hypercapnic alkalosis dysregulates potassium and calcium, lowering the motor neurons' firing threshold and increasing the risk of arrhythmias and muscle cramps. In the dental practice, hypercapnia appears as nocturnal oral desiccation and impaired salivary buffering, creating an acidic environment that accelerates caries. It drives masticatory muscle hypertonicity and impairs periodontal wound healing. The Bohr effect reduction in oxygen delivery slows tissue recovery after scaling and planning. Assessment follows a 3-level stack, from the Bolt score milestone and the Nijmegen questionnaire to the definitive confirmation of end-tidal CO2 capnography. Restoring CO2 tolerance is essential for both systemic and dental health. In our final video, we'll explore the nose as a complete physiological system. The nose is far more than a mechanical filter. It is an autonomic oscillator, a neural pacemaker, and the enzymatic gateway of the enterosalivary nitrate-nitrite cycle. The nasal ultradiene cycle is a rhythmic alternation of dominance driven by the autonomic nervous system. Bypassing this cycle eliminates a 3-hour oscillator from our physiological repertoire. Nasal inspiration entrains the brain. It produces neural oscillations in the hippocampus and prefrontal cortex, coupling the respiratory frequency to memory encoding and emotional stability. The habitual mouth breather disconnects this pacemaker. The resulting brain fog and memory complaints have a neural mechanism that is only correctable by restoring nasal breathing. Salivary glands actively concentrate dietary nitrate, which commensal bacteria reduce to nitrite. Swallowed nitrite becomes nitric oxide, a potent cardiovascular protector and bactericidal gas. Chlorhexidine mouthwash disrupts this cycle by eliminating essential bacteria, leading to a measurable increase in blood pressure. Commensal repopulation is the clinical priority. Restoring the nose completes the structural foundation. Together, these mechanisms form the levee upon which all bioenergetic restoration depends. Orofacial myofunctional therapy is not general fitness for the tongue. It is a targeted training protocol for the genioglossus, the primary pharyngeal dilator. The first mechanism is direct neuromuscular training. Repetitive tongue elevation and suction strengthen the genioglossus through progressive resistance principles. The second is resting posture normalization. Elevating the tongue to the palatal vault increases the genioglossus's resting length, from which it generates sleep protective tone. The third is swallowing normalization. By eliminating the tongue thrust, OMT further elevates the resting position, protecting the airway throughout the night. The landmark 2009 Guimaraes trial established OMT as evidence-based treatment, proving that the upper airway musculature is trainable and clinically significant. OMT recalibrates the airway's mechanical stability. In our next deep dive, we will address oral appliance therapy and the Piper staging protocol. The BioJVA is our bioenergetic bridge, translating the joint's mechanical state into the biometric language that connects the structural levee to our HRV monitoring. We distinguish 4 signatures. The normal profile shows bilateral symmetry below 30 units, while a reducing disc displacement reveals the high amplitude click of recapture. The non-reducing signature is the most clinically urgent, distributed high-frequency crepitus above 300 Hz. The disappearance of the click is not improvement, it is the transition to worsening. Stage 3 is our inflection point. In the acute phase, HRV normalization is achievable through recapture. Once fibrous metaplasia establishes, we face a bioenergetic flaw. Stages 4 and 5 represent anatomical accommodation and articular degeneration. Here, our goal shifts to maximizing HRV within the constraints of the structural damage. The BioJVA provides the early biometric warning of superior stratum failure. In our next deep dive, we address the occlusal philosophies of Dawson and Spear. Custom titratable mandibular advancement devices are the gold standard for dental sleep medicine. Unlike prefabricated ones, custom fabrication allows for the systematic optimization of mandibular position. While CPAP has higher raw efficacy, cardiovascular outcomes show equivalence with COAT. The explanation is adherence. The effective therapeutic dose is approximately equal between the two. The bioenergetic framework adds a dimension. Late-night REM sleep is the most critical for POMC restoration. COAT provides protection through these REM-rich hours that CPAP often misses. Piper staging determines candidacy. Stage 3, or worse, non-reducing disc displacement is a relative contraindication. Advancement increases pressure on already compromised retrodiscal tissue. Where stage is uncertain, the BioJVA provides the non-imaging estimate. An integral above 30, with frequency above 300 Hz, indicates non-reducing displacement, warranting MRI confirmation. OAT is not just a backup, it is a bioenergetic tool for REM protection. In our next installment, we will address the screening to diagnosis workflow and titration protocols. The screening workflow begins with the stop-bang questionnaire. At a score of 3, it achieves 93% sensitivity for moderate to severe obstructive sleep apnea. The dental exam identifies 4 independent predictors: Mallampati crowding, tonsil enlargement, neck circumference, and retrognathia, the find most directly addressable by oral appliance therapy. Titration starts at 70% of maximum protrusion, advancing slowly to 85 or 90%. This protocol balances immediate efficacy with long-term tolerance. Objective titration is not optional. Symptom-based reports are insufficient. We confirm results through repeat sleep studies and real-time monitoring of the nocturnal RMSSD peak. We must weigh the risk of permanent occlusal changes against the bioenergetic cost of untreated apnea, the levy damage of cortisol elevation and mitochondrial shift that no retreatment can reverse. The screening to diagnosis workflow ensures our interventions are both precise and effective. Next, we explore respiratory recalibration and the CO2 training protocol. The CO2 training protocol targets the central chemoreceptor set point, the PaCO2 level at which the brain drives resting ventilation. It converts the chronic hyperventilator back to a normal respiratory rhythm. Phase 1 establishes nasal breathing as a habit. We initiate ZOA restoration through the 90-90 hip lift, providing the tidal volume that resting nasal breathing requires. Phase 2 introduces deliberate air hunger. Reduced volume nasal breathing mildly elevates PaCO2, starting the recalibration process while stimulating mitochondrial biogenesis through nasal zone 2 training. Phase 3 utilizes walking breath holds to produce a simultaneous hypoxia and hypercapnia, a potent training stimulus that recalibrates the chemoreceptors through controlled stress. This protocol integrates with the structural levy to reduce resting respiratory rates. By elevating the chemoreceptor set point, we increase the margin between sleeping PaCO2 and the apneic threshold. CO2 tolerance is the biometric foundation of respiratory resilience. Next, we address the occlusal philosophies of Peter Dawson and Frank Spear. Biometric technology reports what it detects, but occlusal philosophy provides the clinical interpretation. Without a framework, data is numbers without meaning. Centric relation is our skeletal endpoint, where the condyle disc assembly is most superior and anterior, providing maximum decompression of the retrodiscal tissue. The first two Dawson criteria are biophysical specifications, simultaneous bilateral contacts for load sharing, and immediate anterior guidance to inhibit the elevator muscles through a neuroreflex arc. We ensure no posterior interferences during excursion to prevent a muscular tug-of-war, and maintain a stable vertical dimension to prevent driving the condyles into retrodiscal compression. Frank Spear's sequencing operationalizes this destination. Through diagnostic wax-ups and provisionals, we secure the biological evidence of bioenergetic normalization before any irreversible commitment. Occlusal stability is an upstream input to the seventh levy. In our final installment, we integrate these assessments into the root cause hierarchy and the clinical synthesis. Before we walk through the 8 levies and the lab panel, I want to answer a question that's probably already in your head. Why does a dentist need any of this lab data? You're not a primary care doctor, you're not a functional medicine practitioner. You don't manage diabetes or hypertension or thyroid disease. Here's why it matters. The patient sitting in your chair has a cellular battery that determines whether your treatment works. Every implant you place requires that battery to drive osteoblast activity. Every periodontal therapy requires that battery to drive fibroblast wound healing. Every bite splint requires that battery to allow the masseter to relax. Every orthodontic case requires that battery to remodel bone. When the battery is charged, your treatments work on schedule. When the battery is depleted, your treatments plateau, relapse, or fail. The 8 levies are the 8 things that charge or drain that battery. The lab panel is how you measure where the leaks are. You are not diagnosing systemic disease. You are confirming whether the patient's biology can support the dental procedure you're about to perform. That is unambiguously inside dental scope, and it's the difference between dentistry that succeeds reliably and dentistry that succeeds when it happens to succeed. The first levy is light, specifically the alignment of the patient's internal clock with the external day-night cycle. Every cell in the body has a circadian rhythm. The brain coordinates those rhythms through morning bright light hitting the retina. This sets the timing of cortisol release, melatonin production, and the repair processes that happen overnight. When the patient is misaligned, shift work, late screens, no morning sunlight, cortisol stays elevated when it should fall. The deep sleep that drives tissue repair gets shorter. The growth hormone pulse at the start of slow-wave sleep gets blunted. The lab marker is the cortisol awakening response. Morning salivary cortisol at waking, then again at 30 minutes after waking. A healthy patient shows at least a 50% rise. A flat curve, less than 20%, means the first levy is failing. Why dentistry needs this? Elevated nighttime cortisol drives masseter activation during sleep. Your bruxism patient may not have a primary jaw problem. They may have a primary circadian problem expressing itself through the masseter. The cortisol pattern also predicts wound healing. The patient with a flat cortisol response will not heal a periodontal surgery on the same timeline. Knowing this changes your treatment sequencing. The second levy is voltage. This is the patient's mitochondrial capacity, how many they have, and how well they produce energy on demand. Voltage is built through aerobic exercise at low intensities, what's called Zone 2 training. Zone 2 is the single most powerful stimulus for building new mitochondria. The sedentary patient has fewer mitochondria, lower energy reserve, and slower healing across every tissue. The lab markers are HOMA-IR, calculated from fasting glucose and fasting insulin, target below 1.5, and hemoglobin A1C, target below 5.4%, both tell you if substrate is being delivered to mitochondria efficiently. The continuous monitoring marker is heart rate variability from a wearable, target above 50 in a trained adult and above 35 in a sedentary adult. Why dentistry needs this? The diabetic and pre-diabetic patient has impaired mitochondrial function, which translates directly into impaired osseointegration. The HbA1c is not a diabetes screen, it's a healing prediction. A patient at 6.1 will heal noticeably slower than the patient at 5.1. The third levy is the mineral cofactors that the mitochondria need to function. 3 minerals do most of the heavy lifting. Magnesium is required by every step of energy production. Iron carries electrons. Zinc is the cofactor for the enzyme that buffers acid in saliva. The lab markers are RBC magnesium, not serum, because serum is buffered by bone demineralization. Target above 5.0. Zinc plasma, target above 80. And ferritin, target above 50 nanograms, not the lab's floor of 12. 12 identifies anemia, 50 identifies function. Why dentistry needs this? Zinc-deficient saliva buffers acid poorly, meaning the patient is in higher caries risk regardless of home care. Magnesium-deficient muscle cannot relax fully. Your bruxism patient with low RBC magnesium won't respond to a bite splint until repleted. Iron-deficient patients fatigue during long appointments and heal slower. These are the markers that explain your hardest cases. The fourth levy is the fatty acid composition of cell membranes. Every cell membrane is built from fats, and the type of fat determines how the membrane behaves. Omega-3 makes membranes fluid and anti-inflammatory. Omega-6, from seed oils and processed foods, makes them stiff and reactive. The patient with omega-6 dominant membranes generates a larger inflammatory response to every tissue insult, from periodontal pockets to surgery. The lab marker is the omega-3 index. It measures the actual fatty acid composition of red blood cell membranes over 2 to 3 months, target above 8%. Why dentistry needs this? Low omega-3 index means higher periodontal inflammation per unit of bacterial load and faster gingival recession. This single marker explains a meaningful percentage of why some patients have refractory periodontal disease despite good home care. The fifth levy is the patient's antioxidant capacity. Mitochondria produce free radicals that damage tissue if not neutralized. The body's systems require selenium, copper, and glutathione. Heavy metals like mercury or lead can displace these, suppressing the response. Lab markers are serum selenium, target above 120. Ceruloplasmin is the functional copper marker to identify real copper status. And whole blood glutathione, target above 900 micromolar. Antioxidant status is the difference between healing and damage. Why dentistry needs this? The selenium-deficient patient experiencing chronic periodontal inflammation accumulates oxidative damage faster. The same applies to implant sites. Antioxidant status is the difference between healing and damage during the inflammatory phase of every procedure. The sixth levy is the integrity of the intestinal lining. The gut is supposed to be a selectively permeable barrier. When it becomes leaky, bacterial fragments called LPS translocate into the bloodstream. LPS is one of the most inflammatory molecules in biology. Lab markers are zonulin, the protein that opens gut junctions, target below 40, LPS binding protein, target below 7.5. And a stool microbiome analysis showing adequate populations of beneficial bacteria, Akkermansia, Faecalibacterium, and Bifidobacterium. Why dentistry needs this? The gut and the mouth are connected by the same mucosal immune system. A leaky gut drives systemic inflammation. Treating the mouth alone never works in this patient. Identifying the gut component changes the treatment plan and the outcome. The seventh levy is the patient's structural posture, the cumulative effect of pelvis, diaphragm, thoracic spine, and head position. The pattern presses the deep hip flexor against the sympathetic nervous system and compresses the vagus nerve at the base of the skull. It pushes the head forward and the jaw back. This raises cortisol, suppresses recovery, and drives nighttime clenching. The marker here is a physical exam. Ear to acromion distance, more than 2 centimeters anterior to the shoulder, is forward head posture. Check suboccipital tenderness and resting jaw position. A teeth together rest position is a red flag for autonomic stress. Why dentistry needs this? The seventh levy is the upstream driver of the bite problem. An appliance alone cannot fully correct a structural pull. Identifying this pattern tells you whether to add a postural therapy referral. Without it, the splint plateaus. With it, the splint works. The eighth levy is the patient's airway, specifically how vulnerable their pharyngeal airway is to collapse during sleep. Three things determine vulnerability: the skeletal frame, soft tissue volume like tongue or tonsils, and neuromuscular tone. When the airway collapses, cortisol spikes, inflammation rises, and the mitochondria are subjected to repeated hypoxia. Recovery is destroyed. Screening markers include stop bang, target below 3, Epworth Sleepiness Scale below 10, and a Bolt score above 25 seconds. The monitoring marker is the nocturnal heart rate variability deep sleep peak from the wearable, which should be present on most nights. Why dentistry needs this? The airway is anatomically inside your operatory. Malampati, tonsil grade, palatal width. Every patient gets these recorded. The bruxism patient and the worn dentition patient need to be screened. Untreated airway disease is why many dental treatments don't hold. Before we close, there are 4 genetic variants that change how a patient responds to every levy intervention. MTHFR controls the methylation cycle. The TT variant needs methylated B vitamins, not standard folic acid, to make the cycle work. A POE4 is the strongest risk factor for Alzheimer's. Periodontal bacteria have been identified in Alzheimer's brain tissue. Health here is a priority. You manage this patient's periodontal program more aggressively than you would the non-carrier. Periodontal health is dementia prevention. COMT controls stress hormone clearance. The MET/MET variant clears them 40% slower, leading to heightened anxiety and difficulty winding down. VDR controls vitamin D receptor activity. Patients with reduced function variants need a higher target vitamin D level, above 45 rather than 30. These 4 variants change the dose, timing, and priority of every intervention. Knowing the genetics turns generic recommendations into specific protocols. Let me close with the bottom line. The 8 levies are the ways the battery charges or drains. The lab panel measures where the leaks are. You are not diagnosing systemic disease. You are confirming whether the patient's biology can support the dental treatment you're about to deliver. In every state, dentists can order saliva tests. Most commercial labs allow dentists to order the markers we've discussed. Refer when appropriate. The patient with a charged battery heals on schedule. The patient with a depleted battery relapses. The lab panel is how you tell the difference. This is what separates the dentist who reasons from the dentist who guesses. The data is the bridge. Use it. Chapter 24. The Complete 8-Levy Laboratory Panel. Section 24A. 3 Principles of the Laboratory Philosophy. The laboratory assessment in the 8-Levy framework rests on 3 principles. First, measure what the intervention is designed to correct, not what the diagnosis requires. The diagnosis is not the clinical objective. Levy restoration is. Second, use reference ranges as starting points, not endpoints. A serum magnesium of 1.9 will not generate a clinical alert. But an RBC magnesium of 4.1 represents clinically significant third levy depletion, failing to confirm optimal status for mitochondrial enzyme function. Third, measure the levy markers that most commonly reveal the impairments that drive the presentations in bioenergetic practice. Section 24B, the minimum panel. First levy, the cortisol awakening response. Target, at least a 50% rise from waking. A flat response indicates blunted circadian entrainment, pattern B HPA burnout, or obstructive sleep apnea-driven prevention of the nocturnal nadir. Second levy, mitochondrial and cardiovascular, fasting glucose, insulin and wearable HRV 7-day RMSSD average. Third levy, minerals and hydration, RBC magnesium, not serum magnesium, target 5.0 to 7.0, below 5.2 warrants repletion. Zinc plasma target 80 to 120, serum ferritin target above 50, identifies optimal status for mitochondrial enzyme function. Fourth levy, membrane composition, omega-3 index target above 8%. This reflects actual phospholipid composition of cell membranes. Fifth levy, oxygen and metals, whole blood glutathione target above 900. Below 700 indicates significant antioxidant reserve depletion. Sixth levy, gut barrier, zonulin target below 40. Analysis should confirm adequate abundance of Akkermansia and Bifidobacterium. Section 24C, nutrigenomics, the 4 clinically actionable variants. We focus on MTHFR, APOE4, COMT and VDR. MTHFR, C677T TT variant impairs production of methylfolate. Protocol, substitute L-methylfolate and methylcobalamin. APOE4 is a major risk factor for Alzheimer's. We prioritize high-dose omega-3, seed oil elimination, and time-restricted eating. CoMT Val158 MET affects dopamine metabolism. Low-activity MET homozygotes are the warriors who decompensate under high stress. VDR polymorphisms require higher vitamin D levels for the bone remodeling that orthodontic tooth movement and implants require. Chapter 25. Oral Systemic Mechanisms and the Melanocortin Circuit. Section 25A. The periodontal systemic interface at the molecular level. The oral systemic connection operates through three molecular pathways. The first pathway is the LPS-TLR4 pathway. Periodontal disease generates LPS that enters the bloodstream through ulcerated sulcular epithelium. The LPS reaches the hypothalamus through TLR4 expressing endothelial cells, activating NF-kappa B in the hypothalamic microglia. This releases cytokines that suppress POMC neuron firing, producing the beta-endorphin and alpha-MSH deficits of pattern B. Section 25B, the melanocortin circuit and pattern B. The POMC neuron is the master regulatory cell of the melanocortin system. Alpha-MSH regulates satiety and autonomic tone, while beta-endorphin produces the intrinsic analgesia and stress buffering the organism depends upon. Pattern B is a clinical state where sustained cortisol drives DNMT3A-mediated methylation of the POMC gene, reducing its transcription. The result is fatigue disproportionate to sleep, low mood, and a reduced pain threshold. This pattern is not psychological, it is epigenetic. The bioenergetic dental practice addresses three sources: obstructive sleep apnea spikes, trigeminal RAS activation from disc displacement, and periodontal LPS. Addressing these sources participates directly in POMC circuit demethylation, reversing the epigenetic suppression that underlies pattern B. Chapter 26. The monitoring dashboard and the refractory case. Section 26A. The monitoring dashboard, 3 tiers. The bioenergetic monitoring framework operates across 3 integrated tiers. Tier 1 is the wearable monitoring, the continuous 7-day RMSSD average and recovery scores that track the cumulative consequence of all Levy interventions. Tier 2 is the chairside biometric assessment, the BioJVA, T-scan and BioEMG, providing the structural mechanistic information wearables cannot detect. Tier 3 is the laboratory panel, RBC magnesium, omega-3 index and zonulin, providing the biochemical Levy's quantified status. The 3 tiers are not sequential, they are simultaneous. The clinical skill is reading the convergence and divergence of all 3 tiers simultaneously. Section 26.B, the refractory case algorithm. The refractory case, the patient who does not respond as expected, is the most diagnostically informative signal. Step 2, identify the plateau pattern. Which marker is plateaued and which are improving? The plateau pattern identifies the underlying mechanism. Step 3, reassess interlevy interactions. Often the unidentified mechanism is the structural levy operating beneath successful biochemical outcomes. Closing, the unified account. Every dental finding has a biophysical account that begins at the electron transport chain. Before the chair, the physics, then the biology, then the clinical expression. This sequence produces a clinician who can reason. The bioenergetic patient deserves the reasoning clinician. This volume is its foundation. Thank you.
Now that you understand the framework, the question changes. It stops being, what is this? It becomes, how do I actually do this on Monday morning? That's what this video is about. There are 3 pieces of clinical workflow that make the framework executable in a real general dental practice: the pre-operative biomarker panel, the new patient exam, and the monitoring dashboard. Once these 3 pieces are in place, your practice runs differently. You decide treatment sequencing based on actual data, not assumption. Let me walk you through each piece. Every surgical procedure in dentistry, implants, extractions, periodontal surgery, depends on the patient's biology being able to heal. Traditional dentistry assumes that biology is adequate. This is not optional caution. This is risk management. The cost of an implant that fails to integrate is enormous. The cost of running a pre-operative biomarker panel is a few $100s. The same principle applies to non-surgical cases. The orthodontic case that will take 18 months. The full mouth rehabilitation. These cases also benefit from knowing the biological terrain before you commit. The minimum preoperative panel has 8 markers. Let me walk through them. First, vitamin D, 25-hydroxy, target above 45 nanograms per milliliter. The vitamin D deficient patient has impaired osteoblast function and slower bone healing. If the patient is below 30, retest in 8 weeks before proceeding. The vitamin D deficient patient has impaired osteoblast function and slower bone healing. If the patient is below 30, retest in 8 weeks before proceeding. Second, hemoglobin A1C, target below 5.4%. Above 6 significantly impairs healing across every dental tissue. Postpone surgical cases until glycemic control improves. Third, RBC magnesium. Target above 5.0 milligrams per deciliter. Magnesium deficient tissue cannot perform the energy production required for wound healing. Fourth, ferritin. Target above 50 nanograms per milliliter. For healing biology, 50 is the functional minimum. Iron deficient patients fatigue during long appointments. Fifth, omega-3 index. Target above 8%. Patients with depleted omega-3 status generate larger inflammatory responses to surgical trauma. Sixth, high sensitivity C reactive protein. Target below 1 milligram per liter. Elevated baseline inflammation predicts slower healing and increased complications. Seventh, zinc plasma. Target above 80 micrograms per deciliter. Zinc is the cofactor for collagen synthesis. Zinc deficiency translates directly into delayed soft tissue healing. Eighth, salivary cortisol at waking with a 30-minute follow-up. Saliva is dental scope. A flat response indicates chronic stress that suppresses healing. 8 markers. Total cost through commercial labs runs about $300 per patient. This panel is the minimum standard of care for elective surgical dentistry. Timing matters. Order the panel at the new patient exam. The lab takes 1 to 2 weeks to return results. Build that into your treatment planning timeline. When the panel comes back, sort the results. Green markers, the patient is in the target range. Proceed with treatment as planned. Yellow markers, the patient is in the lab reference range but below the bioenergetic target. Recommend repletion alongside treatment but do not delay. Red markers, the patient is significantly below the target. Repletion before elective surgery. Postpone the case for low magnesium, iron, or vitamin D. Refer for elevated CRP. This is the part that protects you. It converts a failed implant into a delayed case with a documented reason. You receive a better surgical statistic. Now let me walk you through the new patient exam itself, expanded to capture the data the framework requires. The exam has 3 parts. Each part feeds the dashboard. Part 1 is the intake form, captured before they sit in the chair. Captures demographics, symptom inventory, lifestyle inventory, and a body pain map. The intake form is a clinical instrument. The right-sided temple plus right-sided neck pain plus low left lumbar tension is the structural pattern presenting itself before any exam. Fatigue plus morning headache is the bioenergetic levy pattern. The intake gives you the working hypothesis before you ever touch the patient. Part 2 is the chairside physical exam. Beyond standard dental, you record postural and airway observations, head position, shoulder symmetry, and airway grading. Each of these is a 5-second observation. Documented together, they become a powerful bioenergetic screening instrument. Part 3 is the technology recording. Record the chairside biometric baseline, resting masseter EMG, BioJ, VA, T-scan, and Bolt score. This is the objective data. How long does this expanded exam take? And how do I fit it into a normal practice schedule? The intake form adds no chair time. The patient does it at home. The expanded physical exam adds approximately 7 to 10 minutes. With documentation built into the chart template, it integrates into the existing workflow. The technology recording adds 20 to 30 minutes for the patient where it's indicated. In a typical practice, this is about 30% of new patients. Total additional chair time for the standard patient, about 10 minutes. For the bioenergetic patient, 30 to 40. Your hygienist can perform much of the data collection. The practices that have implemented this have not slowed down. They have shifted to lower volume comprehensive dentistry with the same or higher revenue per hour. The expanded exam pays for itself in treatment plan acceptance. The patient understands that you are treating them differently than the dentist they saw last year. The dashboard is the integration layer. It takes intake data, physical exam, biomarkers, and biometrics and organizes it so you can read the patient at a glance. The dashboard does 3 things. It shows you the current state. It shows you the trajectory over time. And it shows you when something is off so you can act. Tier 1 is the wearable layer. HRV, sleep stages, resting heart rate. This tells you whether the patient's recovery system is functioning for treatment to hold. Tier 2 is the chairside layer. Masseter EMG, BioJ, VA, T-scan. These update at each recall and tell you if the tissues are responding as expected. Tier 3 is the laboratory layer. Vitamin D, A1C, cortisol, the pre-operative panel. These update annually and reveal the underlying biological terrain. Reading the dashboard is a learned skill. Let me give you the framework for it. First, look at the current state. Are markers in the bioenergetic target range? Second, look at the trajectory. Is HRV trending up over the last 30 days? Is masseter EMG dropping at each recall? This tells you whether your treatment is working. When the chairside markers are improving, but the wearable markers are not, you have a treatment that is helping the dental tissue but not addressing the upstream physiology. Fourth, look for plateau patterns. A marker that stops improving is information. It tells you which upstream variable, airway, or posture hasn't yet been addressed. You do not need to build this from scratch. Start with a structured spreadsheet. Move to custom fields in EagleSoft or Dentrix or dedicated monitoring platforms. The bottom line, pre-op biomarkers tell you if they can heal. The expanded exam finds the levies. The dashboard tells you in real time if it's working. Together, these transform your practice from reactive to predictive. You stop being surprised by failure and start delivering measurably better outcomes.